Hi, my name's Hannah. This is Tate, one of our fellow students, and today I'm going to be completing my lumbar spine assessment. Just prior to that, I just want to apologise, some of my handling will be a little bit altered due to the broken thumb we've all heard about. So prior to completing a spinal examination, I would complete a full subjective history from the patient, and hopefully from that we can exclude any code of equine signs or any red flags. So from that, making sure that we've got no bladder or bowel issues, or that we've got any history of sort of severe osteoporosis, ankylosing spondylitis, things like that. And also from that history to be able to pick up any yellow flags, which is also quite a big contributor in terms of chronic lower back pain. So hopefully excluding all those things, we're going to get started on looking at the lumbar spine. For the purposes of this examination, I'm going to assume that the thoracic spine is clear, and I'm going to work below, but obviously in a normal assessment I would clear the thoracic spine very quickly, okay? But time constraints, I think that would take a bit too long. So, to start with, we're going to have a little look at Tate's posture, so we're going to look from every angle. So, looking from the feet up, and we're looking at, he has got pes planus feet, but it's not translated up to the knees, which allows him fairly neutral hip position. Sometimes if you find they've got severely pes planus feet, can affect the valgus stress at the knee, which increases the Q angle in the hip, which affects the weight bearing up through the SIJ into the spine. But we don't have that on this occasion, so that's great. Tate, could you turn sideways on for me, please? Just pop your hands across your chest. So, going to be looking here at Tate's lumbar lordosis. So, normal lumbar lordosis angle is around 26 degrees. From this position, it's quite nice as well. We can see we've got normal kyphosis. He's got a normal lordosis through the cervical and lumbar there. We can also take the angle of the pelvis, which gives us a nice indication as to the nuation or counternuation of the pelvis. So for this, we go from the PSIS to the ASIS. Normal angle for this is around 15 degrees. And Tate there, I would say it's around 15. If we want to be a little bit more accurate, we could get goniometer, which is a little bit more tricky for this assessment, but we could say PSIS level is approximately here and going to ASIS there. Where are we? Okay, and measuring that, we're at 13 degrees. Okay, thank you very much. So have a little turn around again, please. Thank you. So relax your arms down now, thanks. So looking from the back, looking at Tate's spine, we can see fairly neutral alignment. We're looking for any redness, swelling, or any atrophy in any location. I can't see any there. He is a little bit more depressed on the right-hand shoulder, but are you right-handed, Tate?
Yeah.
Okay, so that can be a normal observation for a right-handed individual. Looking at his PSIS, we're just checking, are these level? Sorry, I've got cold hands. And in this case, yes, they are, which is great. And we can also look at the iliac crests. And it's unfortunately a bit of an eyeball, but we can just check, do they look level? And luckily they do, which is good. In standing, I also like to have a little feel of the erector spinae because we can get a very good idea of the use of them. A normal erector spinae, I would say, does feel like a medium done steak. Overactive tends to feel more like a well done steak. I know it's not very objective, but just in terms of what we're feeling. So Tate is a little bit more active here on the left hand side. Whether or not that's due to a heavy training session yesterday, I don't know. But that would be something that we would mark down in our documentation. Okay, great. So next thing I'm going to ask Tate to do is a little bit of movement. So we're going to go from this angle. I would normally stand sideways on, so I provide a little bit of stabilisation for the patient. So Tate, can you please put your hands on the front of your thighs, okay? And can you have a little bend forwards for me? So from here, what I'm looking at, actually, I think I'm going to turn you around. Do you mind coming back up? We'll just turn you this way. It's just so the camera can see. Just come back a little bit. Thank you. So, and again, just leaning forwards. So what I'm looking at here is Tate getting true flexion through the lumbar spine. We can also look at the angles again of the PSIS and the ASIS. And if we think of the PSIS in terms of vertical and then the ASIS more of a horizontal, we should be looking at 70 degrees there or thereabouts. Coming back up, please, Tate. Let me just have a look at that movement without explaining. So go forwards for me. So I would say Tate's getting a nice hip flexion and lumbar flexion there. I would say that would be normal for him, which is great. Is there any pain or discomfort?
No.
Okay, good. In patients that are very acute, unfortunately they don't have a great deal of movement in that position. So you just see what they can achieve and what they can't. And sorry, prior to that, when we were looking at the posture, with that one we'd be looking for any shift or any scoliosis as well. So obviously not in TAFE's case. So next we're going to move on to some extensions. So this test looks at compressing of the facets. So wait 1 second, sorry. If there's any indication of spondylolisthesis, spondylosis, or facet joint irritation, this test is likely to be positive. However, in very acute patients, again, this movement can be very difficult. This can also be quite uncomfortable with central disc protrusions also. So for this one, I just make sure Tafe doesn't bend his knees, stabilise his pelvis. Tafe, can you have a little lean back for me? Okay, good. And coming back up. And what I'm doing with that, I'm looking for any hinging. Tafe does have a little bit of a hinge around the L3, L4 level, but it's not incredibly significant. And is it painful? No. Okay, fine. Lovely. So if we turn the face that way again, please, Tafe, just so the camera can see. Next one we're going to do is we're going to have a look at some lateral flexion. So put your hands on the side, coming down to the side there, and we can take, the measurement of how far they can get in relation to their knee. So over to the other side. And we can see Tafe's a little bit stiffer on this side. And we're also having a look at the quality of movement. Are we getting a nice fluid bend through the lumbar spine into the thoracic? Or is he fixing, keeping this all very still and moving from his lumbar thoracic region a little bit higher up? But it looks good. Okay, so from there, Tafe, we can also do a little bit of rotation. For this one, I like to stabilise the pelvis. So put your hands across your chest for me. So can you please turn to your left, Tafe? So I'm just keeping the pelvis nice and still. And good, okay, and we're looking again for, he's going to get more rotation through here, but we should get a little bit of rotation through the lumbar spine there. Just stabilise the other side, taking a little turn away, please. Okay, good. And his rotation looks fairly equal as well, which is quite nice. Good, okay, fine, thank you very much. Next, I'm just going to have a little look at Tafe's walking. So Tafe, would you mind please walking up and down? Just to check that there's no antalgic gait, any alterations in his posture when he is moving. That looks fine. If you don't mind stopping at this end, can you walk back, when you turn around please, can you walk back on your toes? So up nice and high as you can, high, good, and turn around, and walking back on your heels. So with these two tests, on the toes we're clearing S1, on the heels we're clearing L4. Any problems there, Tafe?
No.
Good. Obviously in your very acute patients, again, we probably wouldn't be doing these functional, if they've got leg weakness or if they're, acutely in pain, they may not be able to do these movements, so it's just to bear in mind. Okay, good. So, prior to getting down onto bed, I'm just going to turn Tafe around, we're just going to have a little look at his SIJ. Around we go. Thank you very much. Okay, so I'm going to stand slightly side on, but normally I'd stand directly behind the patient. So what I would do is I'm going to get Tafe's PSIS there. And what I'm going to ask you to do, please, Tafe, can you please lift your right leg up? Oh, yeah, as high as you can. Oops, there you go. Try again. Go a little bit higher. Okay. So, and down. Can you do that one again for me? So what I'm feeling for is the movement of the innominate on the right-hand side. And I should find that this drops back a little bit. You're actually a little bit stiff with that joint, Tafe. And down. Okay, let's have a look at the other one. So, can you lift your left knee? Nice and high. You can see on the camera this one moves much more freely. So, slightly indicative that Tafe's a bit stiff through his right hand SLJ. Let me just check I'm not calling your bluff because I have got a dodgy thumb. Go on, let's do this one again. Yeah, so we can see that there's definitely not as much drop in terms of the innominate movement with that. So we'll bear that in mind as we go through the assessment. And in order to clear sort of PARS or spondylolisthesis type symptoms, I'm going to take to do a similar movement. So Tafe, can you bring that knee up for me? And then can you have a little lean back? Ooh, okay, and then back up. Good, all right, and we'll do the other one. So, lifting up. I'm just helping Tafe to stabilise a bit here, just leaning back. So we're also getting compression of the SIJ in this position. So that may aggravate any SIJ pain that the patient may have as well. So that would be, we need to differentiate between those two conditions. All okay there?
Yep.
Lovely, right, fine. If you don't mind having a sit on the edge of the bed for me. Where's my tendon hammer? There it is. So, starting off a little bit about a neurological assessment. So, I'd like to clear Tafe's Tafe's reflexes first. Sorry, can I just pop the bed up a little bit? doesn't go up, does it? Right, okay. So we're going to go patellar tendon reflex to begin with. So just highlight the patellar tendon. Ooh, I've got to be a bit more aggressive with it. Got a little on there. I'll take that. So a little bit dull on that right hand side. Yeah, but that looks like that's normal for you. Yeah, we've got a little on there on the left as well. Okay. So going into tibial. Yep, got a little on there. So just gently into dorsal. Sorry, my handling on this one's going to be a bit bizarre, but you get the idea. Okay, great. Taking your feet up, lie down for me. Oh, sorry, I lied. Just do a clonus before we move you on. So clonus test is just checking for any upper motor neuron lesions. So just relax, relax your foot. So I'm going from plantar flexion up into dorsiflexion, nice and quick. And if you get any reverberation here, I don't know if that's the right word, but tremoring up here that's sustained for longer than around 6 seconds, they need a little bit more investigation. So you check this one as well. So going from plantar flexion up into dorsiflexion, and there's nothing there at the moment, so that's really good. And onto your back for me. And again, another test for, oh, I'm going to need to move you. Just bear with me 1 second. Ooh, sorry, we're moving. Just 1 second there. Okay. Am I going to be able to see your feet here? We can get your right one in, we'll do that. So, just checking Babinski's sign, again for upper motor neuron lesion. So you'd expect with this movement, you go from medial, central, lateral, medial, and you'd expect the toes to claw. If they flare, again, we need to look at further investigation. So that's a negative sign, which is great. Okay, moving on to our myotomes. So looking at L2. So Ted, can you bend your knee up for me? Thank you very much. And can you pull on my hand? So I can be double-handed here. Any problems there? No? Good. And here, can you push straight your knee, please? So L3. Any problems there?
No.
Good. Pulling the feet up. L4 into dorsiflexion. Any problems there? No. And I'm looking for weakness. You may also sometimes get some sensations of pain in the spine with the exertion of the movement. Pulling the toe up here. L5. Any problems there? No. And pushing down on my hands. S1. Any problems there? No. We can also do a little bit of knee flexions. Take and bend your knee for me, please. Into S2. Lovely. Obviously, I'm always going to be comparing left to right, but for the purposes of this examination, I'm just going to crack on with one side, otherwise we'll be here all day. Clearing sensations, well, just grossly to begin with, I'll do a bilateral screen, but if I was to find anything positive, I would generally progress on to looking at a 2-point pin test, or we can look at working with some cotton or some ice just to differentiate a little bit types of sensation that are lacking, or type of sensation that is too heightened, so an allodynian type pain. So initially starting off sort of L2 area, any problems there? Feel the same, Tape?
Yeah.
Yeah. Down into L3, any problems there, Tape? No, good. Any problems there, Tape? No. L5, any problems there? No. And this is a bit like with the feet, any problems here? S1, okay. Into this space here, any problems there? L5 again. All feels the same both sides. Good, so hopefully from that we can assume TAFE doesn't have any altered sensations, so we can progress on to look at sort of straight leg raise tests just to clear these final neurological bits, just pop it down. So looking at straight leg raise, I'm going to make it a passive exercise, so I'm going to pop TAFE's leg on my shoulder and just stabilise his knees straight there. TAFE, any signs of pain or problems, please let me know. So I'm taking the leg up into hip flexion with a straight knee. Any problems there? How does the hamstring feel?
There's feeling a stretch.
A little bit of a stretch there, okay. So I'm just going to bring it down a little bit, and just to sensitise the test, I'm just going to bring a little bit of dorsiflexion there. I'm looking for any pain into the back or any familiar pain to the patient. Any problems there? No. No? I can also put a little bit of perineal nerve bias on by just turning the foot into inversion a little bit with dorsiflexion. Any problems there?
I just feel a stretch on the outside.
Feel the stretch on the outside, and tibial turning into eversion. Any problems there? Feels okay? Good. I think one of the difficult things is sometimes differentiating whether the hamstring is tight or whether the straight leg raise is positive when the patient is unable to explain their pain well. So a nice little test you can do, which compared again left to right, is your popliteal angle, so just checking the hamstring range, which is quite nice there on tape, which can tell you if it's the hamstring tension that you're feeling or if it's the nerve tension that you're feeling. A lot of the time I find with my sciatica patients, I will bring their leg up, but it'll have quite an empty end feel at the point where they say, ow, that's my pain. But it also feels tight, so you can tell then that it's not necessarily the hamstring that's the issue, it's more that the nerve is tensioned, and that is why you can't feel as much resistance in that position. Okay, good. One of the other tests I can do is a slump to sensitise it a little bit more. So take if you just want to have a sit, I'm just wondering where's going to be best. Maybe on that side of the bed. Let me just check the camera's going to be in shot. I'll just turn you a little bit there. Okay. So if I was going to get tape to do a slump, this allows me to have a look at the whole central nervous system and the peripheral nerves working together. So if there's some compression somewhere in the system, this will likely show it up because we're going to look at the mobility from the head right down to the toe. So tape, can you pop your hands behind your back for me, please? Okay, can you tuck your chin to your chest? Okay, now I want you to slump down as far as you can. So really bring these, that's it, bring your shoulders to your hips. Now, can you straighten, let's say this leg, as far as you can go. Good, and then we're going to bring in a little bit of dorsiflexion, so bring the toe towards you. How does that feel?
It's a big stretch.
It's a big stretch. Now, if you take your head up, does that relieve it?
Yeah.
Okay, so we've got a little bit of tension through there, but we can also test if we put your head back down, point your toe. How does that feel? Is that a bit relieved as well?
Fine. Yeah.
Fine, okay. So there's a little bit of tension there when we stress the system on tape, so pop that leg down. Sorry, we'll go again, we'll try the other one just for comparison purposes. So head down, down we go, straighten this one. Okay, how does that feel?
Yeah,
bring that toe up. Is it the same as the other side?
Yeah.
Okay, good. Alright, fine. And we can obviously sensitise and desensitise using head and toe as appropriate. Can actually be a nice treatment as well if we're looking at nerve gliding to mobilise the neural system. Right, okie doke. So if you want to come have a little lie back on your back, thank you. So thinking I've cleared the neural element, so I want to continue and sort the SIJ out just to make sure that that's not a component. So for this, test-wise, we can do the squish and squash test. Generally, I tend to use 6 tests, and there was a paper in 2005 that suggested if 3 of those tests or more were positive, you could be fairly confident that there was a contributor from the SIJ. So we do a squash test, which distracts the SIJ somewhat posteriorly. Any problems there, Dave? Okay. Squish test, sorry, I won't push too hard. So this compresses. Any problems there, Dave? No? Good. Bringing the knee up into flexion, just relax there. So I'm just going to push down onto the femur. Any problems there?
No.
No? Again. So moving the joint posteriorly, there's no issues there. Can you please just come a little bit off to the side? I need to hang this leg off. Okay, so we'd hang this one off down to the floor, and we're going to bring this one up to your chest, and we're going to just push this way. Apart from having a tight hip, any problems posteriorly in the back or around the SIJ? No? Good, okay, and I would compare that left to right, obviously, so back into the middle. So we're assuming now that, hopefully, there's no problems with the SIJ, no neurological component. We've looked at taste, range of move, and we have summarised that he's a little bit tighter there on the right hand innominate. Yep, right hand innominate, which is this one, but he's not getting any symptoms from that. So from here I need to screen the hips out, so bringing, again, left compared to right, but just checking through, so coming into full flexion. Any problems there, Dave? No. Internal rotation, any problems there? External rotation, click, little click in the knee. Some adduction there. Any issues there? Okay, good stuff. We can do, again, favour can assist us in determining if there's an SIJ component, just relax. Or any anterior articulatory problem. No, nothing there, good. It can be quite complicated with hip and back patients with pain to tell which came first. So these tests can be really important to try and help differentiate where exactly the problems come from, because pain from the hip can obviously progress up into the back with altered biomechanics and chronic symptoms of pain. So, good. All right, next one we're going to do, the one I haven't done neurologically is the femoral nerve test. So Tate, if you can turn that way for me, please. I like to do this test inside lying, purely for the fact that I can keep the spine in neutral, and it gives me much more control. So Tate, can you bring this knee up to 90 for me, just have hold of it, just down a little bit. What I don't want to do at this point is take his spine into flexion, because that, not so much of a femoral nerve test, but it can alter the way the nerve is tensioning through the system. So what I would do is take Tate's knee here, stabilise his hip, so I've got a nice neutral spine, and then I can take, I'm not bringing the knee into too much flexion, because if you were to do that, you'll find if they're quite tight with their rect fem, you won't get a true indication of their nerve tension there. And we should be able to get to around 180, so Tate can get to 180. How does that feel?
Fine.
Yeah, it's quite nice, quite soft, there's no hard, there's no tension feeling there, so that's good. Lovely job. Alright, thank you. Right, fine, so I think just while we're inside lying, we'll just have a little look at his range of movement. So if we just bring these back a little bit, bend those knees. Okay, what I'd like you to do, pop your hands out in a palm position there. So I'd like to have a little look at their thoracic rotation in this position. Again, left compared to right, so I find a lot of patients get quite jammed up in their rotation. So keeping this hip still, Tate, can you please bring your arm towards the ceiling? Good, now follow it with your head. Okay, now keep your arm in line with your body, turn your chest. You can let the hip go now. And I want to see how far around we can go. Good. Nice, and I would say that is your knees down. Let's pop your knees down there. So Tate's a little bit tight in that position. Most of my clients can get their chest, most normal rotation, you can get your shoulder near enough to the floor. Come back. So if they're a little bit tight through that range of movement, all being well, it's pain-free. I wouldn't do this if it was painful. I'd get them to work on loosening that mobility with just a few reps through that range of movement. To get one more too. Tend to find each time they loosen just that a little bit. Turn your head, turn your head, turn your head. Lovely. So each time just getting a little bit further. And I'm stabilising the knees to make sure that we're not getting, I feel quite tight.
Feels good.
Feels good? Okay, lovely. Right, so just in this position as well, if I was questioning any instability, so any ligamentous dysfunction as well, I can bring Tate into the shear test, so I can pop him in this position here. And depending on what level I'm looking at, I will stabilise the level above with my hand. And then what I'm going to do is just push through Tate's femur, and what I can feel is the spinous process's stability. So is there a lot of movement through the spinous process below the area that I'm stabilising? And it doesn't feel like that, so it feels quite good. All okay?
Yeah.
Lovely. Alright, fine. Also with this one we can do passive flexion, so we can have a feel of how well the lumbar spine is passively flexing. So again, it would be a similar position here, and this time I put my fingers on a couple of, let's say, we'll say L4, L5 spinal process, and I can wind Tate up into flexion there, and I should feel that the lumbar spine processes are just separating and then coming closer together. That feels quite nice. All good?
Yep.
Lovely. So let's pop you onto your stomach, please. So, in this position, I like to have a look at prone glute range. If you're all rammed up in your glutes, it does tend to pull a little bit into the back. So just take his feet in rotation there, and that looks fine as long as it's equal both sides. I hate to say it, but generally men aren't quite as mobile as women in that range. But if you are too hypermobile, again, it can mean that there's possibly a lack of stability there, or a lack of strength. The last sort of test for the SIJ, which I weren't able to complete in supine, are just your thrust on the SIJ itself, and you can also mobilise each innominate in its oblique plane posteriorly there. Any pain or any problems there, Tate?
No.
Oh, you're definitely stiffer down this side. Okay, so I can just feel that Tate's not moving as well down his right-hand side there. So we can work on it. Okay, so from physio point of view, this is one of the key things for me, is being able to actually feel what the lumbar spine is doing. So I would always work on some palpation, sort of as a final test, so I really understand how these vertebrae are moving. So to find landmarks, I always put my hands on the top of the iliac crest, coming across, and my thumb should land on the L3, okay? So I can put the smaller element, the digit minimi elements there on eminence onto the spinous process, and I can just apply a nice gentle pressure there, and I can feel the mobility of that L3, L4 joint through range, and moving down, L4, L5, and L5, S1. If the patient reports any pain or discomfort, generally indicative that there's either some stiffness or something in that area that is not functioning correctly, we can also have a really nice feel of the resting tone of the erectus spinae and into the QL more laterally. Whoa, you're a bit stiff today. Very tight through there, so TAFE's again a bit tighter on the right hand side, which could again be tied in with this SIJ stiffness that he's got there. From there I would then have a little palpate again down the transverse process. So from the transverse process of L3, you come down one to palpate the transverse process, and then that will be level with L4, and we come down again to palpate on the L4 transverse process bilaterally. And what we're feeling is the nice unresisted movement, which is pain-free. Good. Okay, lovely. Obviously there's multiple other passive mobilizations that we can do through the lumbar spine, for example rotation, we can do some passive extension work as well, but we tend to use these more in terms of treatment than assessment, because if they're provocative and active, then generally I don't feel I need to go through and do them in passive. I'll do them as a treatment method if I feel it's appropriate. So I think, have I tested everything? I think, last couple of just functional tests then before I conclude. It's always nice to have a little look and see how the patient is actually moving and are they able to control the stability of their body in movement. So take you come onto your hands and knees for me, please. Okay, so in this position, I'm going to get TAFE just to come into neutral spine there, which are in Q. And then I'm going to ask him to raise his opposite arm and opposite leg, using the glute to move this leg and maintaining a neutral spine position there. And maintaining his balance. So nice and slow. Good, that's nice. And we can see that TAFE's maintaining neutral spine quite well. He's working quite hard in his erectus spine. He try and engage your core a little bit more. I would have obviously taught transverse, etc., etc. However, the research does not support it. Okay, so TAFE's dropping a little bit more there when stabilising on the right-hand side again. So seeing a bit of a pattern here. So go on, just try and engage deep here a little bit more and just relax there. So engaging deep down in that core. You're definitely better on the left-hand side. Okay, and down. So that's one test that I'm looking for: control of the core, activation through the musculature in erectus spinae, ability to engage the glutes, and obviously balance and control. So that's great. And then one other one that I like to do, take the other turn on your back for me, please. I'd usually do this on the floor, but for the purposes of the camera, we're going to do it on the bed. So pop your hands down by your side, palms facing up, relax your shoulders down. If you can bend the knees for me, please. Okay, so just making sure TAFE's in nice alignment, shoulders, hips and knees in a nice straight line from looking down point of view. So what I'm going to get TAFE to do, can you please tilt your pelvis backwards, so flatten your back into the bed. Good, so I'm just putting a continuation on the pelvis there. Engaging the glutes and keeping the ribs down. It's a bit tough. Can you roll your hips up off the bed, please? So roll your hips, yes, stay there. Good, okay, lovely. So from here, what I'm going to look at, I can also palpate that TAFE's quite active through his erectus spinae there. So what I might do treatment-wise is bring him down a little bit in terms of exercise, but I'll keep you there for now so I can have a look. I'm looking at what that pelvis is going to do. So TAFE, can you please straighten this leg? Okay, so we've got a little bit of a drop there on the right-hand side of the pelvis. Breathe, and foot down. Okay, and other one. Ooh, nice. Okay, so much more stable there on the right-hand side. Okay, and then roll down for me, please. Rolling, rolling, rolling. Okay, so what I didn't do there is I would normally let them just do one to begin with to see what they would do without the tilt of the pelvis, because I find a lot of people just lift up from the back. So TAFE, just do a bridge for me leading from your back. So they tend to just arch a bit more through here, so they tend to push through here. Which is why when they say, oh, into Pilates and it really hurts my back, this is normally why they're not activating correctly through their